Okay.
So there are a few types. There's the first degree AV block, second degree, third degree. And the second degree has two types. Type 1, type 2. Okay?
Okay, well, wait. Let's start from the top. What is a block? What do you mean by that? Do you mean that the electrical current doesn't pass?
Yes. Exactly.
Okay. Now it doesn't pass because of a physiological situation or an anatomical situation.
That's a good point. Let's look and we'll see. All right?
Okay. Okay.
So atrioventricular blocks. A block, it's a delay. So with that in mind, do we have an answer to your question?
Yeah. Okay. So when I think of a block, is that it doesn't go through. But if this is a delay, then it goes through later.
Exactly.
Okay.
So there's an interruption to conduction of impulses from the atria to the ventricles.
Mm-hmm.
All right.
Mm-hmm.
AV, what does AV means? It means atrioventricular. So AV node is the location that we're looking at. Okay.
Mm-hmm.
And see right here, it can occur there, it can occur in the bundle of His or the bundle of branches. All right.
Okay.
And here we have the type of interruptions. It can be a total, meaning
Mm-hmm.
there's no uh, electrical
No.
impulses going through. It
Uh-huh.
could be partial or
Uh-huh.
incomplete, as well as delayed. So it's slow. Okay.
Mm-hmm.
All right. So this can lead to a slow ventricular rate, and this can induce decrease in cardiac output, hypotension, dizziness, loss of consciousness, syncope. All right. What are the causes of these things? Like what can cause an atrioventricular block? Drugs can cause this. A heart condition such as a previous myocardial infarction, and because there's damage to it, the electrical activity cannot go through, and that leads to impairs the ability to conduct. Right.
Mm-hmm.
Surgery can create this as well. Radio frequency and all that. Delay conduction if there's change in the conduction that occurs with aging. This is important. First degree block can be found in athletes that have endurance, high high endurance athletes. Okay.
Mm-hmm.
All right. So first degree AV block, not strictly block, but rather a delay in conduction. It repeats, right, of the depolarization from the atria to the ventricles. It is characterized, meaning one of the things that you're looking for. It's a long and constant PR interval that is greater than 200 milliseconds. How many
Okay.
squares are those, Mario?
200 milliseconds. So each big square is zero point 0.2.
Yeah,
Wait, is that right?
zero point 0.2 seconds.
Yeah, zero point 0.2 seconds. So that means that each one of the little ones is 0.04.
Right?
So zero point 0.2 seconds, that's 200 milliseconds. So bigger than a big block.
Exactly.
Yeah.
Exactly. All right. So good. And the QRS is normal. The reason why the QRS is normal, you know this, because the ventricles are not affected. It is
Right.
at the AV node where we may have a problem. Okay. Or
Yeah.
like we said
So
here, the bundle of His or bundle branches.
so you
Okay.
have the correct atrial activity, and then there's a delay, which
Right.
causes the increase of the length in the PR. Um,
Yes. For the first degree AV block, it's usually asymptomatic. That's why endurance athletes do not have any symptoms. It is very common in athletes. And because they're athletes, they're going to have a high vagal tone. Okay.
mhm.
So there's going to be more of a PNS activity, parasympathetic. And that makes all sense. Right. All right. So consistent long pure interval is what we're looking for. The cure is normal for that individual. And it's going to be a sinus rhythm, meaning we're going to see that P wave. All right. Let's zoom in. And here it is. Long PR. Long PR. Long PR. You gotta measure this, right? And you're gonna see that
Mm-hmm.
the squares is greater than 1 square.
Mm-hmm.
We know that's long. All right.
Mm-hmm.
Look at this one. The second one. Second tracing. The P
Mm-hmm.
wave is actually inside the T wave and it's still normal. And how
Okay.
do we know this is still a first degree AV block? Because we see that P wave every time it's present. That's called sinus rhythm. All right.
Mm-hmm. So the atrium starts depolarizing before the ventricles start repolarizing.
During the repolarization of the
Or during the
ventricle,
repolarization, yes.
it could be because of that, but it's constant. All right.
Mm-hmm.
It's regular. Okay. Now I wrote something here that says, what do you do if the vagal tone is high and the low beats per minute in an athlete? It says, note, in athletes due to high vagal tone, you get them to stand to see the block disappear. So when they stand, they do the ECG, it's going to disappear. This is going to increase the heart rate, and you check to see if it's a physiological thing rather than pathological.
Okay.
Right? Okay, so second degree AV block, type 1, also known as the Wenke, Wenke back. All right, so AV conduction progressively slows until eventually it is blocked. So this is very characteristic. You're gonna see that it will get longer, longer, and then stops. All right,
Mm-hmm.
or there's no more signal going through. Okay, very
Mm-hmm.
characteristic. There's a beat that never gets through. That's what it means when it's blocked. Okay. The atrial depolarization never gets through. There's a disconnection between the P wave not making it to the AV node. Okay.
Mm-hmm.
So in this case, it's going to be regular, irregular. You'll see what I mean. And this is the famous one: longer, longer, lost. The QRS is narrow unless also the block is in the Purkinje uh, bundle of His or Purkinje fibers. Makes sense.
Mm-hmm.
Often this appears with atropine, vagal blocker, or exercise or catecholamines. It usually benign, sorry, unless associated with organic heart disease. Normal in trained athletes as well, due to that high vagal tone. And here we see it. Let's start at the left. We see a PR for a QRS and a QRS for a PR. It repeats. It repeats.
But it's getting longer.
Exactly this one. Every single one is getting longer. This one's getting longer. This one's getting longer. Look at that one. Longer. So longer, longer, lost. There's a P wave, but there's no QRS for that P wave. Do you hear me talking the way I'm talking?
Mm-hmm.
This is the way you talk when you see an ECG. You also have to say there's a P wave for a QRS, but not for every single one. And there's a longer, longer lost tracing that is characteristic of a type 1 winky back um, AV block, second degree AV block. Okay. Any questions?
Mm-mm. And then it starts again. It just starts getting longer and longer again, right? Like once
Exactly.
it skips the beat.
Do you see anything? Let's look at this tracing right here. I'm pointing right here in the middle, and it says there's escape beat. Do you remember what escape beat is?
Yes, that's when the ventricles like they don't receive the signal from the SA node.
Exactly. And so it will pace itself, right?
Yes.
Okay, good. It's like a compensation that, oh, hang on. We haven't received, like you said, no P wave seen from the AV. So it comes from the AV node, junction escape beat, not ventricle, since it's not a broad enough. So it's not the ventricle, it's the AV node in this case. Okay. We're gonna see later the ventricles depolarizing. They're very, very broad. Okay. So in this fourth tracing, it says here that there's a lost P wave, regular, irregular. So this P wave does not conduct, and then the other ones do. Okay. Excellent. All right. So type 2. Remember, the greater the numbers, the greater the type. Sorry, we're second degree. This is going to be more of a pathological, okay? And type 3 is the most pathological type. So, again, less common, but more serious. The block at this point is at the bundle of His or at the bundle branch, right? So it could be, again, a second degree block that what we're going to see is the QRS is going to be narrow if the block is in bundle of His or broad if in bundle branches. Okay, so bundle of His, we're still going to see a QRS being okay. But if it occurs at the bundle branches, we're going to have a problem. In this case, there's no longer lost. All right? So we're going to see an increase in the heart rate that may worsen the block. So it's going to be more evident. Let's see what it says here. More serious, especially if the ratio of non-conducted beats high. So the more P waves that don't make it through the ventricles, the
worse it is.
The worse it gets. Exactly.
What
lower
are the
heart rate,
symptoms of
lower
that?
cardiac output. Everything makes sense. Whoops.
So now you're going to get a bunch of P waves with no QRS.
Exactly. You said it. Second degree AV block type 2 with 3-to-1 high grade block. You said it. We see two P waves. Ventricular rate is very low. Two P waves that have not gone through. So this is 3-to-1. What does that mean? That means that there's 3 P waves for every 1 QRS. Okay? 3 atrial beats for every 1 particular beat. Okay? And this one, we have intermittent second degree AV block type 2 with 2-to-1. So if we look, here is the QRS. That's the P wave. That's the T wave. Here we see a P wave that's not gone through.
And then another P wave.
And then another P wave. So that's 2-to-1. 2 P waves that only produce 1 QRS complex. No lengthening of the PR interval. That is the characteristic part of this one compared to the type 1. Does that make sense? And because it does not happen every single time, it's irregular.
I think you circled those 2 P waves wrong, though, right? I mean, you should have circled the second one and then the one after that.
Yes, you're right. You're right because those are the 2 ones, right?
Yeah.
Yep. Good observation. This is still second degree, more examples.
Okay.
And in this case, it's hard to detect the difference between type 1 and type 2 because as you see, this one's okay. This one, you see here a P wave. You see here a P wave. Here's another one. So it's 2-to-1.
Oh, that's good. Yeah. Wait, why is that one maybe type 1?
Sorry, type 1 or type 2. So type not first degree, but type 1. Type 1 was longer lost.
Second degree type 1 was longer lost.
Exactly.
Yeah.
Yes. So if you look here, apparently it's getting longer and longer. I cannot see it if I don't measure it. But in this particular case, that's what it was said by the professor. Okay. I don't see the longer lost.
Yeah,
Oops.
me either.
But it just says maybe type 1. And this is definitely type 2. But in this case, check out the QRS. The QRS is long.
Yeah, QRS, but it'll be narrower if it's happening in the bundle of His, is what I remember reading a little
Yes,
bit ago.
right. But if it's at the bundle of branch, that's when you see a. If it's a bundle of branch, that's where you'll see um, uh, demonstrating with a broad QRS complex.
Right.
So both type 1 ratio and second degree. So cannot distinguish between type 1 and type 2 movements. You need to conduct the P waves in a row to determine if the PR is lengthening. So that's why it's hard to detect.
Okay.
All right. So third degree block, it's a medical emergency. So remember we said the higher we get, the worse it gets. You may get it's also known as a complete AV block or complete heart block. Complete failure of conduction of the atrial impulses to the ventricles. So there's no sync between the two.
Mm-hmm.
Also known as AV dissociation.
So at this point, the atrium is working, but it's not conducting to the ventricles. So the ventricles are pacing themselves.
Yep. That's why
So
you get
that's
a ventricle escape rhythm.
yeah. So that's why there's no sync.
So the atria will be working, but it's not going through.
Right.
And like we saw it before, right?
Mm-hmm.
The longer lost, that
Mm-hmm.
loss means that it didn't go through. Okay.
Mm-hmm.
So the QRS complex are broad depending on the level of the escape of the block escape rhythm. There's no relationship between the P and the QRS. That's the key feature.
Mm-hmm.
And it requires immediate insertion of a cardiac pacemaker. This was the problem that we went through with Dr. Navas. Okay.
Mm-hmm.
And this is what you see. So no constant PR interval. And the QRS, oh, in this case, oh no, it's not narrow. It should not be narrow. It should be wide. And we see how wide it is.
Mm-hmm.
Okay. So we see the P wave. We see the P wave here. The P wave inside the interval, inside here. All right. How do we know the difference? The key feature is no relationship between the P and the QRS.
Mm-hmm.
All right.
Mm-hmm.
So they're both sending the electrical activity, but they're not coordinated.
Mm-hmm.
The atria and the ventricular rate are regular, but have no relationship to each other. So how do we know that? We see the P wave here, we see the P wave there. That's the same length, same length, same length. But the QRS also has the same length, but to each other. Does that make sense?
Mm-hmm.
Look at this other one. The QRS complex is very, very broad. So that means that the block is somewhere lower into the bundle branch. All right.
Mm-hmm.
So would you like to compare each of them? Because they all look very, very similar.
Um,
1, type 2, and type 3. Sorry, first degree, second degree, and third degree. Quickly, let's do it quickly.
Okay.
First degree AV block is very simple. All that we see is that PR interval is greater than 200 milliseconds or 0.2 seconds. Very simple, and it's seen often. All right. Very characteristic to see this in athletes that have high endurance. Okay, people that run marathons, for example. Second degree AV block type 1, characteristic longer lost. Okay, where was the classic one? Here, longer lost. Okay. Type 2, what we see is what was characteristic for this one? Block a bundle of his, increase heart rate, may worsen. Oh, look at this one. May deteriorate into third degree AV block in type 2. So type 2, what we see is 1, 2, 3, high degree AV block. So there's no longer lost, but we do see that there is the atria are conducting. I'm just trying to figure out. Oh, you know what I think it could be? I'm just thinking because I also see that the QRS is broad in this one, right? I'm trying to figure out the difference between type 2, second degree, and third degree. Second degree AV block. QRS complex. QRX complex. RQ. Okay, so this one is okay, but this one's very broad. This is another one. QRS complex is fine here. QRS complex is fine here. But as we start seeing here, no relationship between the P and QRS. That's when I'm a bit confused. But I do see the QRS complex being broad, but the P wave, I know that there's a dissociation. But I do not see the difference. Do you see the difference between the second degree and third degree type 2, second degree type 2?
Second degree. Between the third degree and the second degree?
Yes.
Yeah, well, third degree has no rhythm. Second degree, depending on what it is, will have a rhythm. If it's type 1, it'll be longer lost. If it's type 2,
yeah,
it'll be various P waves without the QRS. Either 3 to 1 or 2 to 1.
Oh, right.
But it'll still have a rhythm.
You just mentioned it. There is a P wave for a QRS.
Yeah.
In this case. Exactly. Yeah. But it's like you said, there's also disconnection. Like there's no P wave for every QRS. But there is some. But in this case, there aren't any. Right. That's here's one.
Yeah, but if you take a look at like the previous ones, there's no rhythm to it, there's no like this seems to be very haphazard, whereas the other ones have some sort of rhythm because you're going to get 2 to 1, you're going to get 3 to 1, so you'll go P QRS, P QRS, P QRS. Meanwhile, on the other one, you're going to go P QRS, P QRS, P QRS. Like it'll still be a rhythm. I know you Paraguayan people can't dance, but it's rhythm.
Okay, but I do see that here because it's 2 to 1, right? So for every QRS, there's 2. I understand that part.
Yes.
But for this one, you're saying there are 2 here,
Yeah, but
And
okay.
yeah,
So that one is also 2 to 1. It is,
right,
but
right.
there's no like look at the length of the PRs of the
PR
PR set.
inter PR
Like
interval.
there's no rhythm to it. Do you see how this first one is real short? Like
Right.
the
There's a
first one on the left,
disconnection. Yes,
it's
there's a
real short, and
disconnection.
then the next one is a little bit longer. Then the other one is like in between, and then like there's no lengthening. There's no
Uh-huh.
patterns, is what it is. There's no lengthening and there's no shortening, and like
Right, right. Yeah, that's it. You're right. It's all over the map.
yes.
All right. So the antra are regular, but there's no relationship to each other.
And
Okay.
not only are they all over the map, they're also not like
So
there's no pattern of growth, or there's no
exactly,
pattern
like
of.
you said, like the name says, complete failure of conduction,
Mm-hmm,
complete AV block.
mm-hmm,
Whereas in this case, there's some that is conducting.
mm-hmm.
I see it now. Okay, I see it. That makes sense. That's the difference. Good. Now, that's the main part for step one. Know these three different types, and I
Mm-hmm.
think they're easy to know. One is PR interval is long. The second is of second degree. You get type one, which is longer, longer lost.
Mm-hmm.
Easy to see. Winky back. That's the name
Mm-hmm.
for longer, longer lost.
Mm-hmm.
And then you have type one, which is just um, it's just one, right? Sorry.
No,
Longer
no,
long
no,
lost.
no, no, no.
Type
Type
two,
one is longer, longer lost.
yes. Type two means that you get 3 to 1 or 2 to 1, but one of them is conducting,
Hmm.
whereas type three you have no conduction.
Right. There's no rhythm. There's no pattern.
Exactly. Awesome. Now let's go through bundle branch blocks. So
Okay.
we're going deep into the ventricles now, okay?
Okay. This is below the bundle of His.
This is below. I want to say
Well, after, I
yes.
guess, I guess after the bundle of His.
Remember we looked at this one. There was one here. I like this. I think this is bundle of his. I'm not sure. But you see how here is the separate. Yeah, I think you're right. This is the ventricles. The left bundle branch, the right bundle branch. So the Purkinje fibers.
Right.
Does that make sense?
Yes.
Okay. So we have the right bundle branch. We have the left. We have bifascicular block and trifascicular block. Let's go through the anatomy so we have an understanding. And that's exactly what you were saying. This is the right bundle branch.
Mm-hmm.
And we have the left,
Right.
right? Looking for the left, we have the anterior, we have the posterior, and we have the septal. Septal should be right here. Okay.
Mm-hmm.
So, um, was it this one? Remember you mentioned to me, does it depend which artery? And I say, yes, it does. Look at this one. Common in inferior myocardial infarction. So if you have an infarction in the inferior, you might get a left bundle branch block.
Okay.
If you have an anterior myocardial infarction, you might get a right bundle branch block. Okay?
Mhm.
And look at this one. LAD, left anterior descending, septal branch, proximal right bundle branch, and anterior left bundle branch. Um, Posterior left bundle branch, if you get a left anterior descending, and a right, uh, what is it, circumflex artery,
Yes. Uh-huh.
you might get a posterior left bundle branch. All right.
Wait. You might get one.
That means that if you're not always, so if you see a posterior left bundle branch, think about this stuff.
Yes. Yes. But you said you might get one. Like you don't get one from having
Sorry,
problems with the veins.
it's common. It's common to see. That's the
Yes.
word.
Okay.
Not my common. Common
Okay.
to see this. Okay. So they're acquired, but acquired bundle branch common with myocardial and ischemia. It's also common with aging and fibrosis, as it can develop slowly. It's often associated with hypertension, aortic valve disease, degenerative disease. So it's very, very broad, okay? Maybe caused by cardiac surgery, leads to activation of the ventricles, one after the other, all right? So this is very characteristic. So normally, this is what you get for a right bundle branch. Normally, what happens is the right ventricle and the left ventricle um, at the hang on, the polarization of the septum. So at the septum, what you get is this. So they're both going to be conducting at the same time. And so when you see the lead V1, V2, and V3, let me pull that out for a second so we remember what those were.
Those are the front ones, yeah.
Yes. V1, right? There was one that gave a transection view. Where was it?
Have you ever done an EKG on a patient?
On a patient, no, but to someone else, yes.
Okay.
Multiple times.
Okay.
That's how it was part of the
class?
course of the course.
So
So
you
here
guys
we
had
have
an EKG machine.
oh, here we go. Sorry?
You guys had an EKG machine.
For sure. Yes.
Okay.
So here is V1 exactly through the septum. Okay. As we go back, we're going to see that the right ventricle and the left ventricle depolarization at the V1 gives you this characteristic QRS. Okay. This is normal. What you're going to see on a right bundle branch is this. Hang on. From here, you go to this. So you see an R that is bigger. The QRS. The R is going to be bigger. And it's going to pop out at the end.
Wait,
so the right ventricle.
Hold on. Wait. So right bundle branch block means that the right ventricle is going to go later.
Exactly.
Yes. Because the left ventricle is more powerful than the right ventricle. So you don't see the separate ventricles in an EKG because the left one is so much more powerful. So it overshadows it. The left one. But when you have a right bundle branch block, then obviously the right side is getting kind of holed up by the branch block. So now you're able to see the difference because they're not happening at the same time.
Right. But I'm just trying to understand why we see this later. It says that the right ventricle will depolarize from the left bundle. So you're almost done. You're almost there. But the thing is that the left ventricle gets the depolarization. And the reason why it's away is because the ventricle is sorry, not the ventricle. The electrode, it's here. It's here. So you see the depolarization going this way. That means away. Okay?
Okay.
And then we'll see a depolarization from that. Sorry. This is what it means. The right bundle branch block, it's complete. So that means there's no depolarization going through. How is it going to go through? Here, it goes to the left and then comes to the right a bit. That's why we see that. That's why we see this R coming towards the V1.
Okay.
Let's read through everything it says here. So the right ventricle will depolarize from the left bundle. Okay, as I just explained. So there's a time displacement from the left ventricle. That's why we see the R wave coming later. All right. So there's an altered direction of depolarization. We're gonna see an abnormal repolarization, abnormal T waves on the right side of the heart. the ECG average of all the okay, that doesn't make sense. That we don't need to know that. Secondary T wave changes normal for bundle branch block. Altered depolarization leads to altered repolarization. Abnormal T waves should be opposite polarity to terminal deflections of QRS. If if you depolarize hard from alternative route, you will repolarize from alternative route. Okay, makes sense. Does this make sense to you?
Yeah.
All right. And the V1, V2, V3 are the leads that you're looking at. And those are telling you that that's a right side problem. Let's look at the ECG overview. 1, 2, 3. This is the right ventricle.
Right.
Does that make sense?
Mm-hmm.
Excellent. All right. So left bundle branch, you get a characteristic M QRS.
Yeah.
Very M-shaped morphology. Broad QRS. M for Mario, M for block. Left bundle branch block. Okay?
Mm-hmm.
So normally we're looking at the lead 5 or 6. Okay?
Mm-hmm.
Let's go back here. 5 or 6, specifically for that left ventricle. Okay?
Mm-hmm.
You with me?
Mm-hmm.
And as we go through those sides, we're expecting. Okay, I lost it. 1 second. As you go through those sides, you're expecting the left ventricle to receive a high positive deflection because it's coming towards it. Right?
Mm-hmm.
Makes sense.
Yeah, 5 is coming towards it.
Right. The right ventricle should be going away because it's still going away. The combination of both, you get this vector that's a bit smaller than
the LV one, yeah.
Exactly. No. It's just saying that the left ventricle with the right ventricle combined, you're going to get a smaller positive deflection, which is fine. What happens here? It's going to be the same thing. The left bundle branch is blocked. So this is what you normally should be getting. Instead, you're getting this. So you're getting a display in time because the depolarization is coming from the right ventricle. Okay? So it's coming later. So think about this. Everything here normally depolarizes. You get a nice positive deflection. If you have no electrical activity going through here, you need to wait for the right ventricle to polarize and then go around and depolarize that side. That's why when you look at the ECG, you're going to see this M shape. Okay? So I wrote down here that both are blocked, the left posterior and the left anterior. All right? Look at that. Here we see a right bundle branch block because we're looking at the V1. And what do we see? Little r, big S, big R. And the T wave morphology changed. Because you have an alternated depolarization, and that is also going to induce an alternative repolarization. And the same is true for the left bundle branch block. We see the M shape with an inverted T wave.
Okay.
All right? So if we look at the QRS of the opposite side, so V6, we see that it's broad. Okay? How do we know that we're dealing with a bundle branch block? We see the P wave coming through, but it's just one side of the heart that is blocked of the ventricles. So there is electric activity going through, but just to one of the sides. Okay. Well, the compensation is that it's going to go through it, but in an alternate part of the heart. Okay, does that make sense?
Mm-hmm.
Here we have an example of a right bundle branch. How do we know? Remember we talked about the axis determination, the mean electrical axis,
Mm-hmm.
and we said, okay, look at the lead one, it's positive. Look at AVF, it's negative. So
Mm-hmm.
now we see the mean electrical axis and we ask ourselves, where would this be? Would this be on the first quadrant, fourth quadrant? Is it normal? Do you remember?
It would be on the fourth quadrant.
Normal, it's the fourth quadrant.
Yes.
So AVF is negative.
Oh, AVF is negative.
Right. So it's going
So that
away
means that
from
it's
the
going to be on the
AVF.
second quadrant?
No, the second quadrant is the extreme one. So remember, always start on the right, top right. This is your top right.
Yeah.
This is lead one. This is quadrant one, quadrant two, quadrant three.
Oh, I'm
Quadrant
sorry.
four.
I'm sorry. That would be 1, 2, 3, 4. Okay, so that would be the first quadrant
Right.
on the EKG that you showed me.
Yes.
Yes.
So positive here, positive there.
No, positive there, negative there.
Sorry, yes, negative here. Like it says here, AVF is negative. You're expecting it to be here. Look for Hemi blocks as well. It says every time you see that, always look for that Hemi block. So if we look at the Hemi block, we look at V1, V2, V3, V4, V5, V6. Do we see the M shape on the V5, V6?
No. Mm-mm.
But we see something odd,
Mm-hmm.
and the QRS complex is big.
Mm-hmm.
So we see it on the V3 and not the V6. Therefore, is a right bundle branch block.
Mm-hmm.
The rate and rhythm are okay. 5 squares equals 60. It also tells us that there's the right bundle branch block occurs due to this, but we also need to look for a left anterior hemi block. So that just means that one is blocked, the left anterior hemi block. So how do we know that? Well, we've done hemi blocks before, and we know that the left anterior hemi block occurs in this quadrant. Let's go back to the axis determination. Left anterior hemi block. Do you see that there?
Mm-hmm.
So if we go back to the left anterior hemi block and see how to detect those, we're going to see that it says, look for one in AVL, similar morphology with small Q waves in the lateral view. So everything comes up now, right? Everything makes sense. One in AVF, normal morphology, but this is going to be very negative. Lead one is positive towards that way. We're expecting now to see more of a positive deflection on lead two, lead three, and what's the other one? Lead one, lead two,
V1,
and
V2, and V3.
exactly.
For
No, not
right.
lead one. Not lead one. Lead one
I
is on
no
the
no
right.
no 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 V1.
Oh, V1. Yes. And was it lead one?
Hmm?
Lead two, lead three, AVF have a deep S. That's what we're looking for. Deep S. Is the AVL. That's the one I was missing. AVL with small Q wave. So lead two, lead three, and AVF are all having that negative deep S. And AVL and lead one are positive. Those are the characteristics for a left anterior hemi block. Does that make sense?
Mm-hmm.
Okay. So that's how we saw that there are two bifascicular blocks. Right bundle branch block, like we saw here, and a left anterior hemi block. Because of that very negative AVF gave us a clue that we should be looking for that. Okay? Let's see if there's another example. All right. Why don't you do this one?
Okay. So, can you move it over to the right, please, a little bit? Just so I can see V6. Okay.
Is that better?
Yeah, so that one looks to be, so that one has kind of an M-shaped, so it's a left bundle branch block.
Let's start with the medial electrical axis.
Okay, so one is positive and AVF is negative.
It's look what it says there.
Oh, it's biphasic.
Do you see how it's not very negative? I mean,
Yes.
It kind of is. No, it's about the same. Look, it's about the same. It's about the same. It's about
So
the same.
what do you call it?
Biphasic.
Okay, so then that's at 0 degrees.
AVF so it means that because one is positive, AVF is about the same. It means that it's going to be close to 0.
Okay, so would that put you at the first?
So that means it's not. That means it's not very negative, meaning it's not going to be in the left. Sorry, it's not going to be in the first quadrant. It's more likely to be on the right side around 0, which is okay. It's not bad.
Okay.
All right. So now go to the lateral leads, chest leads. Sorry.
So V1, V2, V3, they don't look to have, well, okay, I mean, for sure I know that V5 and V6 have that little M thing, which means a left bundle branch block.
Uh-huh.
Right?
Yes. And what the other observation is that you have a broad QRS.
Okay.
Good. So your V1 to V3 is just very negative, which it's also not characteristic. It should be positive because you're detecting it going towards that side, right? So that's something to be alert with. But I don't see any mentioning of that. How come? See here how it's positive?
So why would it be negative? So it's positive because V1, V2, and V3 are mostly registering from the right ventricle. And it's polarizing towards them, so they should be positive. So in this case, they're mostly negative because it's depolarizing away from them? That doesn't make any sense.
Yeah, I agree with you. I agree with you with this one. Because you're expecting them to be, I mean, on a normal ECG, to be positive, right? But in this case, we see only the M shape on the V6 and V5, right? All right, so bifascicular blocks, right, trifascicular blocks. It's just different combinations that you may get. You may get a right bundle branch block with the left anterior or a left posterior. You may get a trifascicular block, which is the left anterior, right bundle branch block with a left posterior hemi block. So all three. And you may get a atrioventricular escape as well. In this one, you get left posterior hemi block, first degree AV block, and the right bundle branch, or with the anterior hemi block. So here we see On the V1, V2 is very characteristic.
Yes.
Something's going on.
Yes. That looks like
The V5 and
right.
V6 is normal.
Yes. So that looks like a
So
right bundle branch block.
exactly. So you get the depolarization coming from the left side. That's why it's late.
Mm-hmm.
Here we see the AVF is more negative. So therefore you start looking for that left anterior hemi block if your lead one is positive, which it is.
Right. So now you've got the axis on the first quadrant.
Exactly. So you look at lead one and AVL positive. That confirms it. You look at V2, V3, and AVF all being negative. That confirms it. Left axis is deviated, like we mentioned, like you just said it. Then we look for the left anterior hemi block, which confirms it. First degree AV block. That means we need to look for longer, lost, right?
Mm-hmm.
Take a look at this one.
Oh yeah, look at that.
Longer, lost.
Mm-hmm.
And it's very, whereas here it is, so longer. And this one will be inside the QRS, inside the T wave.
Wow. Okay.
I don't know, but we do see it here. I don't see it being consistent or regular, but I do see it. There's a broad QRS, right side chest leads. V2 is abnormal, right bundle branch block. Okay.
Mm-hmm.
Why don't you do this one? Look for the mean electrical axis first.
Okay, AVF is negative. Lead one is positive. So that means that it is the first quadrant, right?
Yeah.
V1
What does that make you look for if it's on the first quadrant?
for Hemi blocks?
Which one?
I'm not sure.
The left anterior.
Oh yes, left anterior.
So how do you look for that? Just think about the position of the leads and everything makes sense.
Left anterior would be on V6, right?
No, you want to stay with these leads. All right. So
okay,
for left anterior hemi block, think about it. Something's going on in the left anterior portion. Those that normally detect the area for those sites are AVF, lead 2, and lead 3. You're expecting them to be positive in a normal situation.
but AVF is negative.
In this situation, because AVF is negative.
Oh, and 3 is negative too.
Exactly. And so is lead 2.
And 2 is negative too. Yeah, they're all negative.
So they're all negative from that side. Therefore, you're expecting more of a positive deflection in another lead. Those are lead 1 and
AVL.
exactly. That gives you the confirmation of a left anterior hemi block. Excellent.
Okay.
Okay, now look for bundle branch blocks.
Okay, so so the lead 1 and 3 definitely have a late spike. So
Yeah.
I'm going to go ahead and say that they are right bundle branch blocks.
Exactly. Look at this one. This one's beautiful.
Mm-hmm.